taking a form of pandemic. We are living in an era where we are seeing multiple pandemic, like the pandemic of the twin pandemic of diabetes, that is diabetes as well as obesity. And they themselves, initially the obesity was only considered as a risk factor for a lot of complications to happen, but now it itself has been approved as a disease. It itself is an inflammatory state. It itself is a risk factor for a lot of mechanical as well as metabolic complications. And this is happening, if you just want to want to be very much simplistic about about this happening, it is because actually we were just made to thrive, and now we are having the problem of plenty, especially when we talk about the caloric intake which we have these days. So poor nutrition as well as undernutrition, they both are malnutrition, and we are facing the, 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 the complication or the consequence of that. So what is this metabolic syndrome? It is a major and escalating public health and clinical challenge worldwide in the wake of urbanization, surplus energy intake, increasing obesity, and sedentary lifestyle. So with mechanization, with industrialization, it has been said that it is this diabetes is actually a byproduct of industrialization. As machines take over, now we are just we are sitting. We are either sitting on the sofa or couch, or in our office, or on the seat of our car, or even in washroom. So we are and it has been proven that sitting is new smoking. It is as bad as being a smoker. So this metabolic syndrome, which we will talk about, it confers a 5-fold increase in the risk of type 2 diabetes mellitus and a 2-fold increase in the risk of development of cardiovascular disease over the next 5 to 10 years. We know that even the diabetes poses the risk of having extra morbidity and mortality, which is largely contributed by cardiovascular disease. The major burden is contributed by cardiovascular disease, and we are also talking about about another condition which portends a bad prognosis independent of the hyperglycemia. It is a constellation of problem which poses the risk of having more risk of cardiovascular disease in the future. It may or may not coexist with diabetes. So metabolic syndrome is defined by a constellation of an interconnected physiological, biochemical, clinical, and metabolic factors that directly increases the risk of atherosclerotic cardiovascular disease, type 2 diabetes, and increased mortality. Unhealthy body measurements and abnormal lab test results include atherogenic dyslipidemia. We know that even a quantitative normal lipid profile also is more atherogenic in case of diabetes. And even when the diabetes is diagnosed, it is usually preceded by a median period of 4 to 7 years of pre-diabetes, which itself is a cardiovascular risk factor, and which itself might be preceded by this atherogenic dyslipidemia, which itself heralds the development of atherosclerotic cardiovascular disease. So this blockade, this much of atherosclerosis, which is being diagnosed in so young population of ours, is they don't happen overnight. They happen over a long duration of time, and it starts when we start having these factors, when we start having these components of metabolic syndrome, that is atherogenic dyslipidemia, hypertension, impaired glucose tolerance or impaired fasting blood glucose, it is a pro-inflammatory state, and it is a pro-thrombotic state. So when we talk about the epidemiology of metabolic syndrome, worldwide prevalence of metabolic syndrome ranges from less than 10% to as much as 84%. Initially, it was only a problem of those mechanized or industrialized world, but now as the industrialization is expanding, even those so-called less developed world like Africa, Southeast Asia, we are also seeing an enormous burden and enormous expansion of diabetes, obesity, and metabolic syndrome. So depending on the region, urban or rural environment, composition like sex, age, race, and ethnicity of the population studied, and the definition of the syndrome used. Like US is having one of the highest prevalence of metabolic syndrome, but there are a lot of other areas also who are not being untouched with this problem. So in general, the International Diabetic Federation estimates that 1/4 of the world's adult population has the metabolic syndrome, which is a huge burden to the humanity. So it is just a, a, a simplification of the metabolic syndrome. So it is contributed by visceral obesity, high triglyceride, low HDL cholesterol, insulin resistance, and hypertension. So how we can diagnose it? So when we follow the International Diabetic Federation criteria, which is being followed vastly. So when the patient is having waist circumference of more than 19 males or more than 80 centimeter in females, though the cutoff varies according to the population of the world, which we'll be discussing in the next slide, plus 2 or more of the following. And when the patient is having BMI of more than 30, this central obesity can be assumed and waist circumference does not need to be measured. And we know that we are having this this lean fat prototype. We are having this 5Y paradox, that with the same kind of BMI, we tend to have more visceral fat. We tend to develop diabetes earlier. We tend to develop the complication of diabetes, that is ASCVD, earlier as compared to our Western counterparts. And likewise, we have different cutoff for obesity for us as compared to Western counterparts. Like we are just obese after 25 kilogram per meter square, not the 30, which is the case with Western counterparts. So plus this obesity or waist circumference higher than the threshold, plus 2 or more of the following, like when we have hypertriglyceridemia, this triglyceride more than 150, low HDL, which is less than 40 in male and less than 50 milligram per deciliter in female, or if the patient is taking any statin or medicine for hypercholesterolemia, if the patient is having medicine for hypertension, or if the patient is having blood pressure more than 130/85, and if any of them is present, the patient would be positive for one criteria. If the patient is having fasting plasma glucose more than 100, or the patient is on OHAs, or is a known case of diabetes. So this, along with 2 of this, would constitute that the patient would be having this prothrombotic and this proatherosclerotic condition, that is metabolic syndrome. So there is ethnic differences. Like Europeans are different, they are having a higher cutoff. We are having a lesser cutoff. Even in Southeast Asia, we are different. Chinese and Japanese, you cannot take the same kind of cutoff. They are having different cutoff with even just 34 inches of their waist. With in Japanese population, they qualify with for this waist circumference obesity as a criteria for obesity. So we will have to have some tests. There are a lot of comorbidities which might coexist. Like a lot of them would be having hyperuricemia, which might be a feature of metabolic syndrome per se. A lot of them would be having non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. A lot of them would be having obesity, and then simultaneously they will have to screen them for other mechanical as well as metabolic complication. As a mechanical complication, they might be having osteoarthritis of knee, or the other degenerative disease of large joints, or the other complication, mechanical metabolic complications, like diabetes or obstructive sleep apnea. Even with obesity, the patient might be having the MOSH, or the male obesity associated secondary hypogonadism, which is a recently titled thing, where there would be inappropriately low FSH and LH, and the patient would be having low testosterone. And we know that the pathophysiology of PCOS as well as type 2 diabetes, and with the metabolic syndrome is same, that is insulin resistance. So we'll have to look for all these things. HSCRP, we know that it is a marker of having cardiovascular disease, as well as we have said that that obesity itself is an inflammatory state. You might be having high CRP in them also, with more fibrinogen, uric acid, and urine milk microalbumin. The WHO criteria includes microalbuminuria also in those 5 points. So, and along with that, we'll have to see that the patient is having any impaired fasting postprandial or any overt hyperglycemia in the form of diabetes or not. So what is the pathophysiology behind it? So metabolic syndrome is a state of chronic low-grade inflammation as a consequence of complex interplay between genetic and environmental factors. So if, like, when we talk about the risk of type 2 diabetes, we know that even if the patient is having one parent as diabetic, he would be having approximately 15% risk of having type 2 diabetes. If the patient is having both their parents as type 2 diabetic, he might be having a risk even exceeding to 30%. So if that would be combined with environmental factors might include the lack of exercise, sedentary lifestyle, food habits, and all of these things would further add in the expression of these diseases. So insulin resistance, visceral adiposity, atherogenic dyslipidemia, endothelial dysfunction, genetic susceptibility, elevated blood pressure, hypercoagulable state, and chronic stress, they are the several factors that constitute this syndrome. So why we need to treat it? Because the purpose of treatment of diabetes and metabolic syndrome and obesity is prevention of complication. It is a continuum of a spectrum. It may start with just abdominal obesity. Previously, there was an assumption that there are people who are having eumetabolic obesity and there are people who are having dysmetabolic obesity. There is no concept such like this these days. Those who have not developed the complication, they might develop in later part of their life. But yes, it would be a thing that would be hurting them. So abdominal obesity, if they would be if they coexist with multiple risk factor, they would further enhance the risk of having hyperglycemia and over diabetes. And even if we don't intervene when the patient is having all these risk factors, like abuse of alcohol, cigarette smoking, sedentary lifestyle, lack of exercise, bad food habits, and if we don't intervene and they develop type 2 diabetes, and if they still don't pay attention to these things, we might result in a lot of complications which would be much costlier to be treated. So abdominal obesity, we have talked about obesity pandemic, which is principally driven by an increased consumption of cheap, calorie-dense food and reduced physical activity. Adipose tissue respond rapidly and dynamically to alterations in nutrient excess through adipocytes hypertrophy and hyperplasia. With obesity and progressive adipocyte enlargement, the blood supply to adipocyte may be reduced with consequent hypoxia. This hypoxia has been proposed to be an inciting etiology of necrosis and macrophage infiltration into adipose tissue that leads to an overproduction of biologically active metabolite known as adipocytogen. So fat is also an endocrine organ which secretes a lot of hormones. So these adipocytogens take part in a lot of processes. So they include free fatty acids. These adipocytogens, they include free fatty acid, pro-inflammatory mediators. They result in local inflammation in adipose tissue that propagate an overall systemic inflammation, which is associated with the development of obesity-related comorbidities. So high caloric intake ultimately results in adipocyte hypertrophy and hyperplasia. This will ultimately result in reduced blood supply to adipose tissue and hypoxia, and then when it would be overburdened, there would be macrophage infiltration, necrosis, and secretion of high adipocytogens due to hypoxia, and this hypoxia will ultimately result in localized inflammation, which would be ultimately spread out to to whole of the body, and it would be resulting into an overall systemic inflammation. So how individual agents lead to pathophysiology of this metabolic syndrome. So free fatty acid. So this splanchnic free fatty acid level may contribute to the liver fat accumulation commonly found in abdominal obesity. And we Southeast Asian, we Indians, as we tend to have more visceral obesity with the same BMI, we tend to have more risk of complication. We see that a lot of people, those who are not even having symptoms, would be having non-alcoholic fatty liver disease, and a lot of them would be having non-alcoholic steatohepatitis also. And it is one of the emerging reason of end-stage liver disease after hepatitis and alcoholism, which is a treated thing. So acute exposure of skeletal muscle to the elevated level of free fatty acid, it induces insulin resistance. By inhibiting the insulin-mediated glucose uptake, the GLUT4 is inhibited. With this excess of free fatty acid, chronic exposure of the pancreas will also result in pancreatic beta cell function, and that would be an insult that would be causing the future risk of diabetes. Free fatty acid also increases fibrinogen and PAI1 production. T1 necrosis factor alpha, it also acts as a paracrine mediator in adipocyte and appears to act locally to reduce the insulin sensitivity. It induces adipocyte apoptosis and promotes insulin resistance by the inhibition of IRS1 signaling. It is actually positively associated with body weight, waist circumference, and triglycerides. So it is not, it is a bad marker. So it will be linearly associated with these risk factor, that when the body weight, waist circumference, triglyceride will increase, TNF alpha will also increase, while it is negatively associated with good cholesterol concentration, that is HDL cholesterol. So HSCRP has been developed and used as a marker to predict cardiovascular disease in metabolic syndrome, and it was recently used as a predictor for non-alcoholic fatty liver disease also. Its level is more likely to be elevated in those who are having insulin resistance along with obesity, but it might be negative in those who are not having insulin resistance, even if they are obese. Interleukin 6 might be an inflammatory as well as having some anti-inflammatory action also. It is also expressed in some parts of the brain, like hypothalamus, where it is associated with appetite control and energy intake. It is major determinant of hepatic. It is a systemic adipokin which not only impairs insulin sensitivity, but is also a major determinant of the hepatic production of CRP. It is positively associated with the BMI, that is, it will be increased as our BMI and insulin resistance increases. Adiponectin inhibits hepatic gluconeogenic enzymes. It is inversely associated with the cardiovascular risk factor. So as the blood pressure increases and the other factor like LDL cholesterol triglyceride increases, adiponectin decreases. Adiponectin expressions and secretions are reduced by TNF alpha. So it is antagonistic it is on the opposite spectrum of TNF alpha. So it is linearly associated with those risk factor, while it is having an opposite relation with those risk factor. Leptin, which is another hormone secreted by our fat cells, it is involved in the regulation of satiety and energy intake. Levels of leptin in the plasma increases during the development of obesity and decreases during weight loss. We are seeing the patients who are having leptin receptor mutation in the, and they might and they are landing in partial and total lipodystrophy, and they require enormous dosage of insulin, while they are seemingly not having any fat in their bodies whatsoever. So besides its effect on appetite and metabolism, leptin also acts in the hypothalamus to increase the blood pressure through activation of sympathetic nervous system. So this insulin resistance is the main pathology behind syndrome X, or this quartet or this metabolic syndrome, those insulin resistance individuals demonstrate an impaired glucose or impaired fasting glucose or impaired tolerance by an abnormal glucose challenge and elevated fasting blood glucose or even frank diabetes mellitus. So when we talk about dyslipidemia, insulin normally suppresses lipolysis in adipocytes. So an impaired insulin signaling increases lipolysis, which results in increased free fatty acid level. And we have explained that this free fatty acid is responsible for more and more generation of triglyceride in the liver, as well as it results in insulin resistance when it reaches in excess to adipose tissue and our muscle tissue. Insulin normally degrades ApoB through PI3K dependent pathway, but when insulin resistance develops, it leads to increased VLDL production, which is the case in frank diabetes also, and it ultimately results in metabolization of this VLDL to remnant lipoproteins and small dense LDL. So even when it is quantitatively normal, it is more sticky and it has more tendency to cause atherosclerotic cardiac disease in the form of stroke, MI, as well as peripheral arterial disease. So this increased free fatty acid level in the plasma ultimately results in increased triglycerides, enriched VLDL secretion by the liver, increased oxidative stress and endothelial dysfunction, and ultimately atherosclerotic disease. So hypertension, essential, which is another part of this metabolic syndrome, is frequently associated with obesity, glucose intolerance, and dyslipidemia. Both hyperglycemia and hyperinsulinemia, they activate the RAS. So how hypertension is a part of obesity and how it is so common with these factors. So actually this hyperglycemia and hyperinsulinemia, they both activate the RAS system, and which in concert may contribute to the development of hypertension in patients with insulin resistance. This insulin resistance and hyperinsulinemia, it leads to sympathetic nervous system accumulation, and as a result, there would be more sodium reabsorption from the kidney. The heart increases contractility and the cardiac output increases, and arteries respond with vasoconstriction, which is ultimately resulting into hypertension. So when these factors are superimposed on genetic factors, so when those who are having more risk of type 2 diabetes and metabolic syndrome in their family, so what are those risk factors? So individuals with type 2 diabetic parents, those who are having Black African race, Hispanic related to Spain or American Indian or Asian origin, they are having more risk. South Asian in urban and migrant environment may be at a higher risk of these disorders due to the confluence of thrifty gene. So this is a hypothesis which says that when we just when we are in intrauterine phase, we are having deficient state and we have adapted to thrive. Whatever excess comes to us, we store it, and we are just comfortable enough with whatever less we get even in intrauterine period. And when there is an excess afterwards, this storage that would be resulting in more free fatty acid and more problem with disposal of that excess substrate, ultimately resulting in such complications like metabolic syndrome, obesity, and diabetes. Environmental influences that lead to weight gain, like lack of spaces where the people can walk, or the other factors, the support a person is having with their society. There's another risk factor which is having its say in pathophysiology, is in the form of chronic stress and glucocorticoid action. This chronic hypersecretion of stress mediators such as cortisol may lead to the visceral fat accumulation, low growth hormone secretion, and hypogonadism, which I've already explained. The glucocorticoids increases the activity of enzyme involved in fatty synthesis and promote the secretion of lipoprotein. Glucocorticoids inhibit and insulin stimulated uptake of amino acid by adipocytes and increases lipolysis, which leads to peripheral insulin resistance. Sedentary lifestyle. So when we are not spending whatever we are eating, when we are eating just for the sake of uh, of being happy, or when we can just order even when we are there, just to celebrate any small moments, so it would be resulting into excess of calories which are not being burned, and the sedentary lifestyle is further uh, exacerbating the development of metabolic syndrome. So what is the solution? The diet and lifestyle modification is the most effective tool which we have to fight with this metabolic syndrome. Uh, when we talk about the healthy weight, uh, if we have to achieve weight loss, we will have to have a negative calorie balance. So we will have to have a good calculation of macronutrients which we are eating. It should not be deprived of enough micronutrients, but macronutrient, especially the carb. We can have any kind of food selection, but that should be sustainable, and that should be having uh, a good representation of microvascular of those micronutrients, and the number of calories they should be less. Like, this is the concept of negative calorie restriction, that when we are taking 500 kilocalorie restriction for 1 week, and then when we would be having 3500 kilocalorie of negative calorie, uh, then we would be losing just 1 pound of weight. So diets restricted in carbohydrate typically provide a rapid initial weight loss. They might be a very good phenomenon, though it is not the only solution, but yes, it is one of the most sustainable kind of diet for weight loss. Adherence to the diet is more important than which diet is chosen. A high quality diet that is enriched in fruits, vegetables, whole grains, lean poultry, and fish. So we'll have to curtail the saturated fat, we'll have to cut the simple carbs, we will have to increase the complex carbohydrate, we should have sufficient protein in our food, we should encourage the people to have this kind of food. Exercise is another aspect which is very important. Gradual increase. Some high risk patients should undergo formal cardiovascular evaluation before initiating an exercise program. The the age of people would be guiding that what amount of exercise they would be requiring. Along with that, we will have to look that what kind of comorbidities and what kind of complication they are already having. Physical activity could be formal exercise. They can do anything, whether it is a mild to moderate exercise, which should be promoted, as well as a brisk walk, or even weightlifting or weight bearing exercises. So this diet and lifestyle modification is the core. When it is not successful and the patient is not able to have those weight loss, then we might add those pharmacotherapy, which is very limited in our country. We are just having orlistat and liraglutide 3 milligram available with us. Lorcaserin is just banned, while other FDA approved, US FDA approved options are not available in our country. And this liraglutide is a very costly option, costing approximately 25,000 per month when we talk about the cost. And orlistat that is having their own problems. So diet and lifestyle modification will have to be there. Even after that, if the patient is failing, then we can add the pharmacotherapy. And when the patient is having, like we are having different cutoff, when the patient is having BMI of more than 30 or more than 27 with comorbidities or complication, then we can offer after these two things with bariatric surgery also. So if we are able to apply this from the very onset, we can we can stop this, or we can at least slow this pandemic of diabetes and metabolic syndrome, and we can reduce a lot of complications in our next generation. Otherwise, if we are not doing such physical activity and we are not paying attention to caloric intake which we are taking, we might be having a lot of enormous burden in the future.
Right. Thank you, Dr. Saqib Khan, for that excellent talk and for showing us the way how to